Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organizations, and the materials covered are by no means an exhaustive list of what can come up in your exam, and indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on Mycobacterium tuberculosis under the section of infectious diseases. So this is a picture of Mycobacterium tuberculosis. As we have previously discussed, it's not extremely common for your MRCP exams to give you slides of bacteria or viruses, but I do think it's important that you have a rough idea about their shape, because certainly they are within their rights to ask you about these in Part 2 written exam, albeit it's not a common scenario. In terms of its epidemiology, it has about 10 million new cases of TB globally every year. And it has the highest burden in Southeast Asia, Africa, and Western Pacific. Approximately 1.5 million TB-related deaths happen per year also globally. And the highest risk populations are those who are on chronic immunosuppressions, including infants, those with HIV that is poorly controlled, and also healthcare workers and people in closed settings such as prisons. The pathophysiology of TB is probably quite well known to all of you. As you know, it is transmitted via airborne droplets from an infected person. You actually need a very low number of bacteria to establish an infection, and therefore close and prolonged contact increases the risk of infection quite significantly. Furthermore, into its pathophysiology, you can divide it into primary and latent infection. The primary infection consists of an initial exposure, which is when the bacilli are inhaled and reach the alveoli in the lungs. Then that will generate an immune response in which the alveolar macrophages ingest the bacilli, within which bacteria will replicate. And that will result in the formation of granulomas, which are immune system attempts to contain the infection by forming those aggregation of immune cells. And granulomas prevent spread of bacteria but stop them from being killed. As for the latent infection, there are generally three important parts. Firstly, it's the containment section, which is quite frequently happen in most immunocompetent individuals, in which the immune system successfully contain the bacteria, leading to a latent infection. And bacteria remain dormant within the formed granulomas. The next part of this is the asymptomatic phase, in which the individuals with latent tuberculosis do not exhibit any symptoms that would make you think that they are contagious. And finally, there is a risk of reactivation in the future, which happens in about 5 to 10% of individuals with latent TB that will develop active TB disease at some point in their lives. And it's really important for MRCP for you to realize that reactivation is more likely to occur in those who are immunocompromised. Talking more about the pathophysiology of TB, in terms of the active TB, you can look into it in terms of three separate phases. First one is the progression from latent to active TB, which is basically reactivation occurring when the immune system is weakened and bacteria can break out of the granulomas and multiply. Initially, it would affect locally and then it will spread more systemically. Active TB can develop in the lungs, which lead to pulmonary tuberculosis or spread to other organs, which is named as extrapulmonary TB throughout bloodstream and lymphatics. And then eventually it can lead to tissue damage. And the tissue damage basically results as an activation of immune response to the active infection, which causes tissue necrosis and cavitation, leading to what we frequently know as the common clinical manifestations of tuberculosis. And these cavitations that are quite characteristic in the lungs, those specific lesions in the lungs are commonly known as tubercles. So, in terms of its clinical manifestation, I'm sure you're all familiar with the signs and symptoms of pulmonary TB. And those include persistent cough that is lasting for 3 weeks or more, hemoptysis, chest pain, fatigue and malaise, night sweats, as well as anorexia and unintentional weight loss. The clinical manifestation for the extrapulmonary TB obviously depends on the site that it gets affected. However, generally, the big red flags for MRCP are evidence of lymphadenitis, which is known as scrofula. Here you can see a picture of a young child with scrofula of the neck. And you also have your constitutional symptoms, including fever, night sweats, and unintentional weight loss. Really the big three that you would be very much expected to ask in, for instance, a PACES scenario. The diagnosis, the gold standard is through biopsy, and the biopsy is frequently gathered through the means of a fine needle aspiration, as well as culture and histopathology. Continuing with the theme of extrapulmonary TB, as I said, in terms of signs and symptoms, it largely depends where else outside of the lung the bacteria has been affecting. If it affects the skeletal system, for instance, the spine, it is what we frequently call as Pott's disease. And the symptoms will include of back pain, deformities such as kyphosis, as well as neurological deficit consistent with cord compression. The diagnosis in that case is going to be MRI scan or CT scan. And as always, the gold standard is through biopsy of the affected vertebrae. TB can also affect the central nervous system, in which case that is frequently known as tuberculous meningitis, which is, as I'm sure you know, infection of the meninges. The symptoms are going to be, as any other case of meningitis, presenting with headache, fever, neck stiffness, as well as altered mental status. The diagnosis is going to be through a lumbar puncture, which you do need to remember very well for your exam, that the result of this is going to be consistent with elevated protein, very low glucose, lymphocytic pleocytosis. And of course, you would be sending the CSF for culture or PCR. TB can also affect the gastrointestinal system, including the intestines, peritoneum, and abdominal organs. The symptoms are consistent with quite a few other abdominal infections, including abdominal pain, diarrhea or constipation, as well as ascites. And the diagnosis is made through acidic fluid analysis and endoscopy and biopsy again. So these are two quite classic examples of chest X-ray findings on active pulmonary TB. On the left-hand side of the screen, you would see a really large, dense, right-sided consolidation. And on the right side of the screen, it's presenting more as a patchy opacification on the chest radiograph. So this is a cavitating lesion presenting on the right upper lobe, which is secondary to TB. Cavitating lesions are quite famous in terms of MRCP exam, and it's really important for you to know the differentials for cavitating lesions, which tuberculosis is one of the most important ones. So the diagnosis is made through clinical evaluation, including a history and physical examination. The important laboratory tests include sputum smear microscopy for Ziehl-Neelsen staining, culture and sensitivity, PCR testing, tuberculin skin test, as well as IGRA or interferon gamma release assay. And you would want to be scanning the relevant parts of the body that you think the patient may be symptomatic from. And that includes in almost all cases a chest X-ray, and a CT scan or an MRI scan of the relevant section, such as the spine. The management of tuberculosis is through anti-TB medications, and these include the first-line drugs consisting of isoniazid, rifampicin, ethambutol, and pyrazinamide. And the initial phase of these 4 drugs are for 2 months. This will then continue to a continuation phase, which is for 4 months, that you will be dropping 2 of these and you will only be continuing with isoniazid and rifampicin. The second line drugs, especially for drug-resistant TB, include fluoroquinolones and aminoglycosides. And the regimen for drug-resistant tuberculosis, such as multi-drug resistant TB, is usually much longer, lasting for anywhere between 18 to 24 months. And of course, you do need to be speaking and be guided by your local infectious diseases team for appropriate treatment of these cases. Let's talk about prevention. The biggest prevention in the UK is through the BCG vaccination, and also tight infection control, especially in those who are at higher risk, such as those working in healthcare setting and in the community. There are a couple of important public health strategies that are used globally in different countries. These include direct observed treatment, and this is for patients who are particularly at high risk of lack of compliance with treatment, that they would be invited to come and have the treatment and the anti-tuberculosis medication swallowed in front of a healthcare worker such as a nurse or a pharmacist. And again, different countries do have different screening and prophylaxis treatment options for high-risk groups such as those in prison. Okay, let's do some questions. Question 1. Which regimen is commonly used in the initial phase of treatment for drug-susceptible TB? A. Isoniazid, rifampicin, ethambutol, and pyrazinamide. B. Isoniazid, rifampicin, ciprofloxacin, and pyrazinamide. C. Rifampicin, ethambutol, ciprofloxacin, and isoniazid. D. Isoniazid, rifampicin, levofloxacin, and pyrazinamide. E. Rifampicin, ethambutol, linezolid, and pyrazinamide. If you recall, the standard treatment for the initial phase of a drug-susceptible TB is going to be option A, which is isoniazid, rifampicin, ethambutol, and pyrazinamide. A good mnemonic to remember that is RIPE. R for rifampicin, I for isoniazid, P for pyrazinamide, and E for ethambutol. Question 2. A 50-year-old male presents with a months-long history of night sweats, weight loss, fever, and a non-productive cough. Physical examination reveals enlarged cervical lymph nodes. What is the most likely extrapulmonary manifestation of TB in this case? Options are A. Pott's disease, B. Gastrointestinal TB, C. Lymphadenitis or scrofula, D. Renal TB, E. Miliary TB. The correct option is going to be option C, which is lymphadenitis or scrofula. So this is quite a straightforward case because they have given you a very classic presentation of pulmonary TB in a 50-year-old patient with night sweats, weight loss, fever, and a non-productive cough. However, they've also told you that on physical examination, you have picked up enlarged cervical lymph nodes. And if you recall, the cervical lymph nodes that are enlarged associated with TB is known as lymphadenitis or scrofula. Therefore, option C is the correct option. Thanks for listening to this episode of Bite Size MRCP. If you like what you heard today, give us a thumbs up and hit the like and subscribe button to make sure that you don't miss out on our next episode. Let us know in the comments which topics you would like to hear in the future. See you in the next episode.